Good morning, everyone. My name is Catherine Arkell, and I'm an intern at the World Health Organization in the Department of Reproductive Health and Research. I will be facilitating today's webinar that is jointly hosted by the World Health Organization's Regional Office for the Americas, which also known as Pan American Health Organization, and the Department of Reproductive Health and Research. ADOSME from Implementing Best Practices has kindly agreed to manage the logistics for this webinar. Next slide. The purpose of this webinar is as follows: to provide an overview of the WHO Guideline development and unique process of meaningful community engagement in this development of the 2017 WHO Consolidated Guideline on Sexual and Reproductive Health and Rights of Women Living with HIV, to present the new recommendations in the guideline, and to gain insights from national and regional stakeholders regarding implementation of the guideline. Just like to go over some rules quickly. During the presentations, feel free to type any questions that you may have in the question box of the control panel on the right-hand side of your screen. At the end of the presentations, I will direct your questions to a panelist. If we do not have time during the webinar to answer all of the questions, we will send responses after the call. Please note, the guideline itself has been uploaded into the handout section, which is also located in the control panel on the right-hand side of your screen. Feel free to download and share it. Next slide. We have many panelists who are experts from the region and WHO. Some of our speakers will be presenting via recorded video, while others will be speaking live. However, please feel free to address questions to all of the panelists. Also, be aware that there is a slight delay when transitioning to and from the videos, and this is not a sign of a poor connection. I would like to briefly provide an overview of the structure of today's webinar. We will be starting with two speakers, Manjula Narasimhan and Alice Wellborn. Manjula will be live and Alice will be live video. And they will provide an introduction to the guideline and some background on the unique process of meaningful community engagement used in its development. This will be followed by presentations describing the new recommendations in the guideline. These will be given via video by Avni Aman on safer disclosure of HIV, Anna Pilar-Bertrand on elective cesarean sections, and Bella Ganatra on safe abortion. Next slide. Next, Violetta Ross will present live the new recommendation on self-efficacy and empowerment. This will be followed by Mona Lufti, who will cover best practices in health service delivery and research. We will then hear from Sonia Cafe from PAHO on some next steps for the region. We will wrap up with a question and answer period. You're welcome to type your questions in the question box on the control panel on the right-hand side of your screen at any point during the webinar. They will be answered during the question and answer period. Now, it is my pleasure to introduce our first panelist, Dr. Manjula Narasimhan. Manjula, please go ahead.
Hi, good morning, everyone, and thank you so much for being on this webinar. Thank you, Catherine. I wanted to, in this presentation, provide a brief overview of the key principles behind the development of this consolidated guideline on SRHR of women living with HIV. This guideline was published in February 2017 and is the outcome of a broad consultative process involving national, regional, and global experts. The rationale and the scope of this guideline is because in so many countries, women living with HIV do not have equitable access to good quality health services and are also faced with multiple and intersecting forms of stigma and discrimination. Women living with HIV are also disproportionately vulnerable to violence and violations of their sexual and reproductive rights. This guideline starts from the point when women already know they are living with HIV, and women who are not aware of their HIV status must first be reached by safe, voluntary, non-coercive HIV testing and counseling. In addition, although this guideline focuses on women living with HIV, it is acknowledged that the sexual and reproductive health and rights issues are in many cases similar for all women. This guideline is meant to help countries to more effectively and efficiently plan, develop, and monitor programs and services that promote gender equality and human rights and be more acceptable and appropriate for women living with HIV. Next slide, please. Firstly, a WHO guideline is any document that contains recommendations about health interventions, whether they are clinical, public health, or policy interventions. The rigorous process, evidence retrieval, and methodology on how these recommendations are developed is described in the GRC handbook that is shown on this slide. GRC standing for Guideline Development Committee. The next slide, please. This slide and this guideline, it consciously adopts the perspectives of women, their families, and their communities. It's really grounded in and advocates for a strengthened, comprehensive, women-centered approach to SRHR. And a women-centered approach, we mean an approach that sees women as active participants as well as beneficiaries of trusted health systems that respond to their needs, their rights, their preferences in holistic ways. It's an approach that emphasizes the promotion of gender equality as central to the achievement of SRHR. It's an approach that requires that women are empowered through education and support to make and enact decisions in all aspects of their lives, including in relation to sexuality and to reproduction. It's an approach that calls for strategies that promote women's participation in their own health care. It recognizes the strengths of women living with HIV as active agents in relation to their sexual and reproductive health and rights, and not merely passive recipients of health services. And finally, it's an approach that is grounded in the health needs and priorities of the women themselves, rather than an approach that is focused on disease management and control. Next slide, please. Unique to the development of this WHO guideline is a global survey which was conducted by and for women living with HIV to assess their SRHR priorities, and so that their values and preferences could be placed at the heart of this guideline. And you will hear more about this unique process of meaningful community engagement from the next speaker. To note here that this guideline is intended to address women living with HIV in all their diversity. It captures diversity also across age groups, emphasizing that health services that promote SRHR are important for women throughout all stages of their life, from adolescence to postmenopausal years. Next slide, please. The framework, therefore, shows the key principles at the center of this document. In addition, you will see in blue the health interventions and in purple the enabling environment. Both are important because it is recognized that while policies and programs and interventions to improve SRHR for women living with HIV exist in some places, these alone will not bring about the improved health outcomes in the absence of a safe and supportive enabling environment. So this consolidated guideline seeks to bring together both new and existing WHO recommendations and good practice statements into one document. The following 3 slides show a summary of the key topics that were identified for this guideline. Next slide, please. This slide shows the topics that were identified for the recommendations. Next slide, please. And this one shows the one for good practice statements. Next slide, please. This framework, therefore, that was developed for this guideline supports recommendations and good practice statements that can reduce the sometimes significant barriers women living with HIV face to accessing and utilizing high-quality SRH and HIV services. We recognize, though, that many excellent initiatives, programs, and policies already exist in the region. And in implementing these global recommendations and good practice statements, the regions and countries can adapt them to their local need. Next slide, please. In conclusion, therefore, an integrated approach to health, human rights, and gender equality lies at the heart of ensuring the dignity and well-being of women living with HIV. Action on the recommendations in this guideline therefore requires a strategy that is not only informed by evidence and appropriate to the local context, it must also be responsive to the needs and the rights of the women themselves. I look forward to receiving feedback on how best to implement this guideline in your country and your region so that we can overcome barriers to service uptake, use, and continued engagement, reduce stigma and violence, and deliver the highest quality care. Thank you.
Thank you, Manjula. We'll now go to the videos where we'll cover the meaningful community engagement as well as the 3 new recommendations.
Thank you. So greetings everybody. I've called this part of the webinar with my slides the power of positive participatory processes, because that's really what it's about, how powerful a participatory process can be. And this was very much a community-wide engagement, and you can see all of those wonderful different logos there as an example of this. So this was a values and preferences survey which fed into the new guideline and which informed the guideline in relation to many different issues faced by women living with HIV in all of our diversity from around the world. So there was a real sense of intentioned community engagement from the outset. So we had a core team leading the process, and 2 of us are women living with HIV, Mary Jo Vasquez and myself. And then we also invited wonderful women from around the world who in many ways are also really great activists and who have many different diversities in terms of how we have acquired HIV, whether maybe we've grown up with it, whether we've acquired it through drug use, whether we also identify as sex workers or lesbians or bisexual women, whether we are immigrants or whether we are indigenous communities, and whether we're transgender women. So there were a lot of different diversities represented in this global reference group. So the Global Values and Preferences Survey itself was created and led and informed by this global reference group. So as we shaped the questions which we had in the survey, they were questions which came from the global reference group members and were shaped by them, highlighting key issues which affect all of us in our lives in different ways from around the world. It was the largest survey ever of women living with HIV. In the end, we had 832 online respondents on our SurveyMonkey website, and we also had another 113 who took part in focus group discussions. We had 7 different languages and more with the focus group discussions, and the respondents were also from a diverse range of backgrounds and experiences, all of them women living with HIV, aged between 15 and 72. In terms of the methodology, we adopted what we call an appreciative inquiry approach, which is a positive approach building on women's agency and resilience and courage to cope with the many different issues that they face in life. And it was also a life course approach, looking at the whole range of experiences across a lifetime. It was grounded in human rights. It produced both quantitative and qualitative results. As I said, the survey was both online, and also we had focus group discussions in some countries to make sure that some women who don't have online survey access could take part. And it really identified and expanded upon those key priorities identified by the global reference group members initially. So what findings did we have? Well, we created this beautiful house image out of the many and complex different findings that we produced. And as you can see, there are fundamental foundation stones, most of all at the very base: safety in healthcare at home, in the community. Though there are those wall pillars, those panels, human rights, gender equality, social justice, our meaningful involvement in everything which affects our lives, and protective laws. Then we have those different parts of the roof, our sex life, our pregnancy and fertility, treatment and side effects, and so on. And then we also have these three beautiful birds taking off at the top. And the idea of this was to say that if you achieve our sexual and reproductive health and rights, then not only will we benefit, but also our partners, our children, and our community will benefit. And this was a key message which we really wanted to get across, that first and foremost, if we're able to achieve our sexual and reproductive rights, then everything else will follow. And that the idea of this house was to present a safe haven for women living with HIV in all of our diversities around the world. We achieved this. The women who filled the form in said how much they had enjoyed and appreciated doing the survey. And we really feel that this is the way forward, and that how so many other surveys and guidelines could be developed in future. Thank you.
My name is Apni Amin, and I'm a Technical Officer for Violence Against Women in the Department of Reproductive Health and Research. I will be talking about addressing violence experienced by women living with HIV and the WHO recommendations for this. Why should HIV services address violence experienced by women living with HIV? Data published by WHO in 2013 show that women who experience intimate partner violence are 1.5 times more likely to acquire HIV in some regions of the world. Survey conducted of women living with HIV and their values and preferences for the production of these guidelines for women living with HIV show that 89% have experienced some form of violence. Systematic and other literature reviews on HIV disclosure show that experience of fear of violence is a barrier to HIV disclosure and to accessing treatment and care services by women. Politically, in May 2016, the 193 member states of the World Health Assembly adopted a global plan of action on health systems' response to addressing violence against women and girls, and in the global plan of action identified sexual and reproductive health and HIV services as key entry points for integrating actions to address violence against women. In the Consolidated Guideline on Sexual and Reproductive Health and Rights of Women Living with HIV, there are 2 new recommendations for addressing violence against women living with HIV. The first is aimed at policymakers and service providers and raising their awareness that many women living with HIV who are considering HIV disclosure either fear or are experiencing or at risk of intimate partner violence. The second recommendation goes beyond raising awareness on actions to be taken by service providers, and this includes discussions about the challenges of their situation, potential risk of violence, and actions to disclose HIV status more safely, and also to facilitate links to available violence prevention and care services for those women who disclose that they are living in a situation of violence. So those guidelines build on previously issued guidelines by WHO in 2013, which were aimed at healthcare providers to respond to intimate partner violence and sexual violence. And so the 2013 guidelines include 5 recommendations for healthcare providers. The first is on asking about intimate partner violence. And the WHO recommendations are to use a clinical inquiry approach, which is based on signs and symptoms, and asking women when they see these signs and symptoms, rather than universal screening. So WHO does not recommend universal screening. The second recommendation is for offering first-line support to those women who disclose intimate partner or sexual violence. And the first-line support are adaptation of the psychological first aid, which has several steps including listening empathetically, offering non-judgmental response, addressing the woman's practical needs, and linking her to different social support services. The third recommendation is to train healthcare providers at both pre- and in-service level in how to ask and to offer first-line support. The fourth recommendation is to integrate care for women experiencing violence into existing services rather than having standalone services for violence against women. And the fifth recommendation is that mandatory reporting of intimate partner violence to the police is not recommended. To help operationalize these guidelines and recommendations, in 2014, WHO published a clinical handbook called Healthcare for Women Subjected to Intimate Partner Violence or Sexual Violence. This clinical handbook has a number of job aids and tools with practical instructions on how to implement the recommendations. One of those tools is around implementing first-line support, which we call LIVES. And LIVES has basically 5 steps. Listen to the woman empathetically, inquire about her needs and concerns, including physical, social, and practical needs, validate by showing and assuring her that she's not to blame, discussing a plan for her safety, which is the enhanced safety component, and the fifth is to facilitate social support by connecting her to information and other services. Forthcoming in 2017 and 2018 are 2 addendums that we will make to the clinical handbook. The first is for family planning providers to support women experiencing violence with safety in choosing contraceptive methods, and the second addendum is for HIV providers to support women experiencing violence with safety in relation to HIV disclosure, which will help operationalize the recommendations contained in the new consolidated guidelines for women living with HIV. In addition, we will also be publishing a manual for health systems managers on how to design, plan, and monitor and evaluate services for violence, and a training curricula for both pre- and in-service level for healthcare providers on violence against women. Thank you.
Hello. This presentation will briefly explain and contextualize the recommendation on mode of delivery. An elective cesarean section is a cesarean section that occurs before the onset of labor and before rupture of membranes. Elective cesarean section has been recommended as a mode of delivery for women living with HIV infection in order to minimize HIV transmission to the newborn. However, the past decade has seen important shifts in HIV clinical practice and management. As the underlying risk of perinatal transmission during delivery is associated with disease stage and antiretroviral use, evidence in the past may not be relevant in current practice. For this reason, WHO has conducted a systematic review and meta-analysis to assess maternal and perinatal outcomes, comparing elective cesarean section with other modes of delivery in women living with HIV, but also according to type of therapy, viral load, and CD4 counts. This systematic review provides the updated evidence for the new recommendation in the guideline. Elective cesarean section should not be routinely recommended to women living with HIV. In 2015, WHO released a statement on cesarean section rates, which emphasizes that cesarean section should be undertaken only when medically necessary. And rather than striving to achieve a specific rate, efforts should focus on providing cesarean section to all women in need. As with any surgery, a cesarean section poses risk for women, particularly in settings that lack the facilities or the capacity to conduct safe surgery or to treat surgical complications properly, or where access to labor care or repeat cesarean section in subsequent pregnancies cannot be taken for granted. Because risks and benefits differ across settings, and for individual women, depending on the underlying risk of complications from a surgery such as cesarean section, and the underlying risk of vertical transmission of HIV during delivery, the evidence suggests that routine elective cesarean section for all women living with HIV without further considerations may not be appropriate. The decision to undertake a cesarean section should emerge from careful and personalized consideration of all the factors playing a role. How to translate this recommendation into practice at point of care and how to discuss with each woman and address each woman's need may present numerous challenges for both healthcare providers and women. Tools need to be developed for this purpose. The WHO Department of Reproductive Health and Research is committed to developing tools to support implementation of this new recommendation, It is important that these tools are practical and reflect the needs of the end users. Potential tools being considered are infographics to support healthcare providers, but also for women living with HIV, so that they have the information necessary to make an informed decision. Thank you very much.
The elimination of unsafe abortion is one of the key elements of the reproductive health strategy that was endorsed by the World Health Assembly in 2004. Components of eliminating unsafe abortion include comprehensive sexuality education, access to contraception to prevent unintended pregnancies, safe abortion care when unintended pregnancies do occur, and the treatment of complications when abortions happen unsafely. Women living with HIV have the same needs for all of these services as do other women. This guideline explores the questions of clinical care for women living with HIV. In particular, it looks at the question of whether surgical and medical abortion are both effective and safe options for women living with HIV. Medical abortion is the use of drugs, mifepristone and misoprostol, in order to terminate a pregnancy, and surgical abortion refers to the use of transcervical procedures like manual vacuum aspiration in the first trimester and dilatation and evacuation at later stages of pregnancy. The WHO's Safe Abortion Guidelines recommends that both of these methods are safe and effective options, and women should preferably have a choice of both of these methods. Does this recommendation hold equally true for women living with HIV? Are there any particular concerns related to bleeding, related to the vomiting induced by medical abortion drugs that might be different for women living with HIV? These are the questions that this guideline in particular explored. The systematic review did not identify studies that directly compared outcomes of abortion in women living with HIV with other women. However, no concerns or adverse side effects were reported in women living with HIV, and issues related to bleeding and vomiting with drugs are relatively minor side effects of the abortion procedure. Hence, the guideline makes a recommendation that women living with HIV should be offered the same options for both surgical and medical abortion as all women. If only one of the options is available, women living with HIV who desire voluntary abortion should receive the available option. Women living with HIV should not be coerced into terminating their pregnancies as a result of their HIV status, or be coerced into accepting long-term contraception post-abortion if they do not wish it. But it is equally important that women living with HIV, when in need of safe abortion care, should receive this. It is important to create an enabling regulatory environment and to ensure that additional barriers are not faced by women living with HIV. Thus, safe abortion care and post-abortion care must be an integral part of all comprehensive reproductive health services for women living with HIV. More specific information on the provision of safe abortion care services can be found at all of these resources, which are available for download at the HRP website.
We will now hear from Violetta Ross, who will speak on the new recommendation on self-efficacy and empowerment in the context of her own experiences. Go ahead, Violetta.
Hello, everyone. It's my pleasure to be here with you today. I'm just going to try to bring an understanding from the point of view of women living with HIV on this recommendation. Interventions on self-efficacy and empowerment for women living with HIV. My own experience is that I am a rape survivor, and that's how I found my HIV test when I was 23. I am almost certain that I got HIV from one of my 2 perpetrators, but I cannot be sure. And this is the experience of many women living with HIV. Of course, my little intervention will reinforce everything that has been said by previous speakers on gender-based violence, especially the fact that 89% of the women living with HIV that responded to the global survey experienced gender-based violence, not only by intimate partners, but also by health workers, by community, neighbors, and family. And there is an after, and there is a before and after the HIV test. And we know the HIV status increases violence. I have seen and I can witness the reality of this context in which this recommendation has to be implemented. I can tell you at least about 2 examples of women living with HIV in Bolivia who have been killed after disclosing their HIV status. The same for transgender women and sex workers. It's very common in Latin America, and I suspect not just in this region. So I was thinking, how can this recommendation really become real for women living with HIV? Well, we cannot do this without ignoring this context that I am referring to. One, of gender-based violence that begins in early childhood for many women living with HIV, and also a context of different vulnerabilities. It's not just the HIV test, it's also the level of poverty, the activities of the women, the drug use, or the identities, like the case of the transgender women, and the fact that these experiences go as far as childhood, and the women have never had, many women living with HIV have never had a support on their families. So when the HIV test happens, it's just an excuse to commit more violence against many of these women. And then how to transform this? In Bolivia, we made a small research about gender-based violence with women living with HIV, transgender women, and sex workers. And we practiced some of those participatory methodologies that Alice Welborn was referring to. We used the body mapping. We asked the women to body map the violence they experienced and also HIV. And actually, the exercise of listening to one another in a safe environment on the experiences of being tested HIV positive and also being having experienced different forms of violence was a healing process, and that was the best outcome of that research. I think many women do not have these spaces, and this is one way of practically implementing this recommendation. Where can the women speak about their test, about their difficult choices around sexuality and reproduction, if it's not in a safe environment? And for this to happen, we need to change, but not only us, also those who take care of us, our families, including our partners. Of course, it begins with the woman, and the guideline is very good on that, presenting an approach that is centered to the woman, but the woman cannot change the world alone. We need the support from other people and partners that are around us, all of us included. And this is what the reflections that I wanted to bring. I can tell you many experiences, not just one case, of many women living with HIV in Bolivia, in Chile, in Argentina, etc., that are still questioned by health providers when they decide to become pregnant. Still, there is a lot of questioning of the women living with HIV, blaming the women living with HIV because there might be a transmission, even with the information that we have now on how possible it is to have babies as a woman living with HIV. And I cannot speak a lot about economic empowerment of women living with HIV. I see many of my colleagues, my friends living with HIV, wish they could do more, but they stay in situations of violence and risk of death because they need something to live out of. They need money to feed their families, and so they will stay with the choices they have now, which are very poor and very weak in terms of self-efficacy and empowerment. And my last point is that if we want the women to be self-efficient for their sexual and reproductive health and rights, this is not going to be a one intervention in just after the test. The woman will need support when she's tested and after, and when she grows old, when she decides to have kids, when she has to disclose to the larger family, when she's finding a job. All of these stages, she will need continuous support from health providers, from family, from neighbors, and of course from her own community, women living with HIV, and other women who are also not living with HIV. These are some of the reflections that I wanted to bring based on the many experiences of women living with HIV that I met around the world. Thank you so much.
Thank you so much, Gracia. Now we will have Dr. Mona Lufti, who is going to speak on best practices in health service delivery and research in the Canadian context. Go ahead, Mona.
Great, thanks so much, Catherine. Can you hear me okay?
Yeah, it's great.
Okay, great. So I'm going to present some data from Canada, just showing how relevant this guideline is to Canada. I think it's interesting to present the Canadian context because, as Gracia presented in Bolivia, everyone thinks that in low and mid-income countries, that's where there's a lot of gender inequality. But really, gender inequality is an issue all over the world, including in Canada, other North American countries, and in high-income countries. So, next slide. Before I start, what we do in Canada is we always start by acknowledging the land where we're meeting. This is a nice meeting because it's international, so we can be thankful for the land all over the world. Very important to do so today because it's June 21st, which is the first day of summer. And on the first day of summer in Canada, it's actually National Aboriginal Day. So the Canadian land was first owned by the Indigenous people and who lived on the land, and in the 1800s colonizers came and took their land, and as I'll show you, there are issues remaining today because of that colonization. And the land where I am in Canada is called by the Indigenous people Turtle Island, and Turtle Island is actually all of North America. There were no borders before, and so I'm very grateful to be living in Turtle Island. Next slide. And so what we've done in Canada, like Alice said, we worked with women living with HIV to run a national cohort study called the Canadian HIV Women's Sexual and Reproductive Health Cohort Study. We hired and trained women living with HIV to be research assistants using community-based research practices, and we enrolled 1,425 women living with HIV across Canada. You can see there we started in British Columbia, where we enrolled 356, 713 from Ontario, and another 356 from Quebec. And next year we'll be adding in green the provinces of Saskatchewan and Manitoba. And surveys were done with these 1,425 women, and they're being repeated every 18 months. Next slide. And so here are some demographic results, and I think you might be surprised by some of them in terms of the experience in Canada. So if you just look at the total column, the average age of the women were 43. We did something called purposive sampling, where we tried to recruit as many trans women and women of other gender diversities. And we were relatively successful. We enrolled 64 trans women across Canada, so we were excited about that. We had diversity in terms of sexual orientation and also in terms of ethnicity. So you can see that 22% of our population was Indigenous. And this is important to understand, since only 3% of the entire Canadian population is Indigenous, which are called either First Nation, Métis, or Inuit. There, you can see that there's an overrepresentation amongst women living with HIV that are Indigenous. So, so HIV is a problem amongst our Indigenous communities. 41% identified as white, and 29% identified as African, Caribbean, or Black, and 7% as other ethnicities. Another crisis in Canada has to do with injection drug use. So 1/3 of the women had a history of injection drug use. The problem that we're having now is related to, we have fentanyl that is being distributed across Canada, and we have high overdose rates. And also shocking, 37% had a history of incarceration. Next slide. This is other shocking results from our study. While 84% of the women were educated, and even some highly educated, look at this, 65% were living below the level of poverty with an income less than $20,000 per year. So a real issue of poverty amongst women living with HIV in Canada. And 36% identified with a validated scale of being food insecure, and 11% having unstable housing. Also consistent with the global survey that Alice spoke about, half of the women met criteria for depressive symptoms, and a really important result and issue to address for women living with HIV, and 69% had a history of childhood violence, and 80% had a history of adulthood violence. So as Gracia reviewed, a very important topic. Next slide. Despite all the negativity, what's really amazing is the resilience of these women, or the self-efficacy, as Gracia and Amangela have called it. We had a resiliency scale, and with a maximum of 70, and the average resiliency amongst the women was 62.2. Really incredible, and to work on this positive side with the women. Next slide. So in conclusion, I just really wanted to summarize that I'm very happy that the WHO has come out with these consolidated guideline on sexual and reproductive health and rights of women living with HIV, because they're relevant to Canada. We do have the high rates of violence, food insecurity, and depression amongst women living with HIV in Canada. There's a great need for peer-driven programs, self-efficacy programs, even in Canada. And there's some unique challenges to Canada, which I've already mentioned. Next slide. And so what are we doing? With this data, we're developing a model of care, which we're calling women-centered HIV care. This is an initial model that was published in a literature review in Journal of International AIDS Society in 2013, but there's a more operational model that'll be coming out, and which is great timing in terms of coinciding with the operationalization of the WHO consolidated guideline. Next slide. we always end by acknowledging the women who have died in our study, CHIWOS, and it's unbelievable to think, but 33 women out of the 1,425 have already died in the short 3 years. Next slide. I'd like to thank our funders as well as our partners, including clinic and community partners. And next slide. And we're really excited to announce that we'll be launching in the fall a bi-monthly webinar with all of these partners there, including the WHO and our study called CHIWOS, a webinar series that will be reviewing the priority topics relevant to the guideline on sexual and reproductive health and rights of women living with HIV. And so we hope you'll join us. We'll have topics like trauma and violence against women, safe disclosure, peer leadership, and the self-efficacy that Gracia spoke about. So stay tuned to hear about those webinars. Thank you very much.
Thank you so much, Mona. Now we're going to hear from Sonia Cafe from PAHO about the next steps for the region.
Thank you very much, and good morning to everybody. I would like to acknowledge all the presenters who went before me, and also several of the good friends and colleagues I have seen as I scroll through the window of attendees, also partner agencies who are attending. And prior to making this very brief presentation, I just want to acknowledge that it's definitely not the intention to suggest that PAHO would be the only one implementing or supporting these guidelines in the Americas. We have several other very critical partners who will also be implementing or supporting implementation, and we would definitely reach out to all of you to partner so we can effectively support the rolling out of this global guideline. What I'm going to present in just 2 slides is what the PAHO process is usually to implement global guidelines. Next slide, please. And so in the extension of the normative function of the World Health Organization, PAHO as the regional agency, the regional chapter, is also performing this normative function in the sense of providing our member states with normative guidance on service delivery, on programs, on implementation. And in that sense, in the past, people who have been working in the past with PAHO, we tended to develop regional versions of global guidelines. Over the past years, the decision was made that we will not be doing that duplication of services, but rather to accelerate adoption of global guidance, we would rather focus immediately on implementation in the region, and that includes translation, because we need to have these normatives in the languages that are spoken in the region. We have already started with the translation into Spanish and Portuguese, and also using the French versions for countries such as Haiti and the French territories. And the dissemination, of course, we disseminate through our networks, which includes the Ministries of Health, but definitely also other partners. The second role that PAHO has is advocacy. We advocate with our partners for adoption of standards, because again, we have a mandate on standardization of services, reaching universal health coverage and access for quality health services. And since these evidence-based guidelines, our role will be to advocate with our member states to adopt them. And the third one is capacity building of key stakeholders. And the fourth one is to support implementation on the ground, meaning incorporation of the global standards in national strategies and operational strategies, and also to model the implementation with our member states. Next slide, please. And the fifth is monitoring and evaluation. One of our critical roles as PAHO is to continue to prepare regional reports based on a set of indicators to support operational implementation research and to reflect where we are based on the information that we gather. So those would be the 5 key issues that we will be following up on in harmony with other regional partners. In addition, just to inform, is that we, for the Caribbean, we already have a commitment from a network of IPPF affiliates who want to do their own lounge. These are family planning associations that work very close on the ground with women, with stakeholder groups, and also with women living with HIV, and they would be they prefer to do their own lounge with their stakeholders on country level and in the sub-region of the Caribbean. And so we would also be supporting those types of initiatives coming from the ground to further to advance the adoption and the implementation of these guidelines. Thank you very much.
Thank you, Sonia, and thank you to all of the panelists for their excellent presentations. We have a few minutes left only, but we will now move to the question and answer. Please type your questions in on your control panel on the right-hand side. Our first question is for Manjula. Someone would like to know, how did the process of developing these guidelines differ from the development of other WHO guidelines, and how will the process used for this guideline inform forthcoming guidelines?
Hello, thank you for that question. The WHO guideline process, places a strong emphasis on issues such as human rights, gender equality, and the voices of the end user. However, what we did that was quite different from other guidelines in this process is to hear from the community of women living with HIV at the start of the process. This is, even before we developed the PAHO questions and the systematic reviews, we first supported the global community survey as was described by Alice, and the outputs of that really informed the language of the guideline and the positive language that we have tried to use throughout, but also in the way the recommendations have been developed. We are working with the Guideline Review Committee to see how we can further strengthen the issues related to meaningful community engagement in other guideline developments, and as well as trying to build capacity so that the evidence that does exist from experiences such as those that Violetta has described can be translated into peer-reviewed publications, into evidence that we can retrieve and include within our guideline development. So that's an ongoing work that is taking place, and hopefully will support further guideline development. Thank you.
Thank you, Manjula. I think we might be able to squeeze in 2 questions here. So this next question is for Mona. So there are individuals who would like to know how to sign up for these webinars, obviously very keen. And also asking, though, how did you choose the provinces in which to conduct the survey? And a thank you that you did a fabulous presentation.
Okay, thanks so much. So I think it's cut off from the bottom of the slide from the webinar, but there is a contact coordinator named Rebecca Gormley. And so for information, you can email her, and Catherine can type it in to the webinar box. GORMLEY at cfenet.bc So rgormley@cfenet.bc.ca. And you can just email her to add you to the list for when we have officially pick the dates, and you'll get that email out. But they'll also be widely advertised. We'll send out. We'll launch information on wide listservs, including the one where you found out about this one. So I wouldn't worry about it. Manjula will make sure that you know about it. And in terms of how we chose the provinces, BC, Ontario, and Quebec are the largest provinces in Canada, and 80% of the people, I think it's 80%, it could be 70%, but or 60 to 80% of the people living with HIV from an epidemiologic standpoint come from those provinces. So that's why we started with British Columbia, Ontario, and Quebec. And then the next three provinces that have the highest epidemiologic numbers are Alberta, Saskatchewan, and Manitoba. So we reached out to those provinces. We couldn't get off the ground in Alberta, but in Saskatchewan and Manitoba, we did make connections, and that's why we're rolling out there. And there's a very important epidemic of HIV happening in those provinces, which we call the prairie provinces, amongst Indigenous populations, particularly in Saskatchewan, where right now there's an incident rate of HIV of about 16 per 100,000 when the national average is 6 per 100,000, and in some regions it's higher, even 100 or 300 per 100,000. And so that's why it's another reason why we're rolling out into those prairie provinces. So thanks so much.
Thank you, Mona. So I think in the interest of time, we're going to have to stop there. I want to thank you all for participating and for your insightful questions. Please join me in thanking the panelists, IVP, and other stakeholders that made today's webinar possible. Any questions that weren't answered will be followed up on. And we'll be sharing the recording of the webinar with everyone and also posting it on HRP's YouTube channel, Media HRP. Next slide, please. And the address is on the screen right there. We welcome further thoughts on dissemination and implementation of this guideline, so please feel free to send these directly to Manjula. And thank you again, everyone, for your participation. Have a great day.
Thank you, everyone. That was really terrific. Thank you.